We're going on to the next speaker, Dr. Yasir Sepah. Yasir, are you with us?
Yes, I'm
Hi.
with you.
Hi, how are
Hi.
you doing? Yasir
Good.
is nice to see you even virtually. Yasir is a senior clinical research scientist in Stanford University, and he is going to deliver his talk on OCT imaging of patients with autoimmune yes, OCT imaging of patients with autoimmune retinopathy. Sorry, I have to wear my glasses.
So my talk is a recorded talk, I think.
Yes.
Hello everyone, my name is Yasir Sepah. I'm a senior research scientist at the Byers Eye Institute at Stanford and the co-founder of Ocular Imaging Research and Reading Center. One of my primary research interests has been to correlate the structure and functional characteristics in eyes with autoimmune retinopathy. So today it is an honor that I'll be sharing with you some of our findings thus far. Here are my disclosures. The term autoimmune retinopathy encompasses a broad spectrum autoimmune pathology, which can either be paraneoplastic or non-paraneoplastic in nature. Patients typically present with rapid, progressive, and painful visual loss bilaterally and often present with unremarkable fundi. But the most unique unifying factor among these patients is the serologic presence of anti-retinal antibodies. The two most commonly found and widely studied retinal antigens are recoverin, which is a calcium binding protein located in photoreceptor and bipolar cells, and alpha amylase, which is a glycolytic enzyme expressed in many types of tissue serologically. However, it is not only expensive and not widely available, but there are also poor lab testing concordance rates. Additionally, presence of these antigens is not limited to autoimmune retinopathy patients. ERG is currently the most commonly employed ancillary investigation to establish the diagnosis of autoimmune retinopathy in conjunction with clinical and serological findings. However, ERG is lengthy and invasive and may not identify early disease. Although spectral domain OCT is a quick and non-invasive procedure, it has not yet been thoroughly evaluated in autoimmune retinopathy patients. Avazeri et al. Has used a time domain OCT to characterize some of the features of eyes with autoimmune retinopathy, while Pepel et al. Has reported only subjective correlations between findings in eyes with autoimmune retinopathy scanned with different imaging modalities. We hypothesize that tissue loss in autoimmune retinopathy can be quantified by using spectral domain OCT imaging and designed a study that would allow us to compare the thicknesses of retinal layers in eyes with autoimmune retinopathy to eyes with no ocular pathologies. We additionally wanted to examine the correlation between any structural changes that we could establish with the SDOCT and visual function assessed by ERG. This was a cross-sectional study which included 22 eyes from 11 adult patients with autoimmune retinopathy. These patients' diagnoses of autoimmune retinopathy were established by a uveitis specialist and confirmed by serological testing. High-resolution spectral domain OCT raster scans and full-field ERGs for each of the 22 eyes were obtained as part of the standard of care at the first visit at which the patient presented. OCT images were analyzed at the Ocular Imaging Research and Reading Center, while ERG interpretation was performed by a graded mask to the OCT findings of each patient at Stanford. For those of you who are not familiar with OCT imaging, the image on the right depicts a cross-sectional view of the retina along the horizontal red line on the left image. Thickness values of each layers were assessed in 0.5 millimeter increments along each B scan, up to 2.5 millimeter both nasally and temporally from the center of the macula. Thicknesses were also averaged across the 5 millimeter lines, yielding a central thickness value. These recorded values were then compared to corresponding values derived from 100 eyes of 100 subjects with no known ocular pathology. The cross-sectional scans were segmented along a 5 millimeter horizontal B scan, passing through each fovea in order to obtain the thickness of individual retinal layer. All of the lines were reviewed by two experienced graders. The retinal layers which were analyzed included the retinal pigment epithelium, the photoreceptor layer, the bipolar cell layer, the combined ganglion cell and inner plexiform layer, the RNFL, and the combined ganglion cell layer plus RNFL layers, and of course the full retinal thickness. 5 eyes of 3 patients were excluded from the analysis due to the presence of confounding ocular pathologies, a unilateral subchoroidal lesion in one patient, bilateral full thickness macular hole in another patient, and bilateral geographic atrophy in another patient led to exclusion from the analysis. Among the remaining 9 patients, 17 eyes were included in the analysis. Mean age and median age were both 52, and there were 5 males in the study population. Within the control group, mean age was 42, median age was 41, and there were around 50 males. Now let's go over the results. Eyes with autoimmune retinopathy showed a general loss of retinal tissue compared to eyes with no known ocular pathology at the foveal B scan. The bipolar layer was the only layer that did not show significant thinning in any patient. For the rest of the presentation, all normal eyes will be represented by green lines, while all eyes with autoimmune retinopathy will be represented by the red line. In this graph, we have plotted full retinal thickness in 0.5 millimeter increment along the B scan passing through fovea. And as you can see, 35% of the patients showed significant thinning of the full retina. Overall, the full retinal thickness experienced a loss of 35 microns, which is around 13% of change. The retinal pigment epithelial layer also showed significant thinning. The RPE experienced a mean loss of 8 microns, which was around 28% of the total change that we had observed when we looked at the full retinal thickness. Similarly, we observed around 18 microns of loss in the photoreceptor layer. Though the RPE had a greater percentage loss, the micron loss of photoreceptor layer contributed far more significantly to the overall loss in full retinal thickness. The photoreceptor loss contributed almost half of the total retinal thickness loss that we had observed. As mentioned earlier, we did not see any change in the bipolar layer when compared the autoimmune retinopathy eyes with normal eyes. We did observe a loss of around 7 microns in some of the patients, around 24% of the patients that we looked at through SDOCT without retinopathy. Similarly, the retinal nerve fiber layer in 29% of the patients showed around 2 microns of loss that we termed was statistically insignificant. Although, when looked at individually, the ganglion cell layer and the nerve fiber layer did not show significant thinning. However, when we combined the two layers, the thinning became more evident, and the combined GCL and RNFL layer experienced a loss of around 11 microns that contributed 34% to the overall full retinal thickness. So, in conclusion, we could say that it is important, if you're looking at the ganglion cell and the nerve fiber layer, to combine the thicknesses of the two and compare with the normal eyes to show if there is any significant thinning. Now let's talk about our ERG findings. Central photoreceptor, both rod and cone dysfunction, was noted in 63% of the eyes. The ERG findings correlated strongly with the loss in the photoreceptor layer. ERG findings demonstrated a functional deficit that showed very good correlation with the structural loss that we had documented through the OCTs. 50% of the eyes experienced central photoreceptor dysfunction. 75% of eyes displayed peripheral photoreceptor dysfunction. The figure in this picture demonstrates a comparison of SDOCT and ERG changes between a normal eye and an eye with autoimmune retinopathy. Now, what happens when we look at these patients longitudinally? We had 5 subjects with AIR around 10 eyes that we had a follow-up of 2 years or longer. These patients remained clinically stable on various therapies. However, the overwhelming result that we noticed was that the loss in retinal tissue was progressive despite being on treatment. The cross-section study has been published and is accessible on PubMed. In conclusion, eyes with autoimmune retinopathy show loss of retinal tissue compared to normal eyes. The greatest loss appears to occur in the RPE and the photoreceptor layers. ERG findings correlate strongly with the loss of tissue seen by OCT, and OCT may be an effective tool in the management and follow-up of patients with AIR. Therapeutic options may be targeted to preserve the RPE and photoreceptor layer. And lastly, through our longitudinal assessments of 10 eyes, we have concluded that the current therapies do not seem to stop the loss of retinal tissue, and this loss persists even when the patients are clinically stable. Thank you for your time.
Thank you so much, Yasir. This was very interesting. So one question, I mean, you said that the patients were clinically stable, but did you also did an ERG on this patient? So the ERG was stable, or it was decreasing, or it was, I mean, showing changes
So, yeah, that's a great
along
question.
with the OCT findings? They were
Yeah,
consistent?
So clinically stable means on examination, these patients remain stable. They may have had a flare or two here and there, but there wasn't, at the time of that last exam, all these eyes were quiet. The ERG, there were, for 4 patients, there were ERGs along with the OCTs, and they correlated exactly the same way as that what we had seen in the cross-sectional study, which made us start thinking about whether any of these treatments actually work as far as the preventing the loss of tissue is concerned. the therapies may control some of their initial clinical signs and symptoms, vitreous haze or leakage or any other clinically noticeable sign, but it seems like the tissue loss is progressive, and the ERG loss is also progressive.
Thank you. So any questions, comments?
Congratulations for your lecture. My question is the only one. Do you think that this clinical entity, ocular clinical entity, is an isolated clinical entity, isolated in the eye, especially in the retina, or there will be the future a systemic association with another systemic autoimmune disorder?
So that's a great question.
Or even in a case of a paraneoplastic syndrome, but in the future, because sometimes we have an autoimmune disorder in the eye other than autoimmune retinopathy, and after 5, 6, 7 years in the follow-up, we are in front of a systemic, either autoimmune systemic disorders or a malignancy.
So that is a very interesting question. From what we have noticed is your observation may be correct that the reason we divide autoimmune retinopathy into paraneoplastic and non-paraneoplastic is that in the same patient, during the history of the disease, initially we may have termed it as non-paraneoplastic because we didn't find any evidence of any cancers. But later on, we may either find one and then the definition changes. So in most of our patients were also very old age. There were, I think the average age was around 67. But we didn't have, there was only one patient who had a history of confirmed history of cancer. So it's out there. I think it's possible that we may eventually discover that some form of cancer either precedes or follows the diagnosis of autoimmune retinopathy. But as far as the current evidence that is available to us is concerned, I think it can be both. There is some form of autoimmune reaction within the eye that gets triggered even in the absence of a neoplastic syndrome present.
So whenever we have one of these patients, and as we know, and perhaps Lucia will address when her talk next to us also.
Thank you, Kwan, for jumping in. It's a pleasure to see you. Hi, Kwan. Lucia is also online, and her talk is going to follow on autoimmune retinopathy, so you can both comment.
Yeah, I was going to say that as part of our evaluation, whenever we have a patient, especially an elderly patient, who happen to make the diagnosis based on various criteria for AIR, we also take very caution to evaluate that patient for underlying potential malignancy as well. So we don't just let it go and just assume that because they have antibody against the retina, the optic nerve, that is automatically AIR, because we're also concerned about what has been just mentioned, that there could be an underlying potential malignancy. And but even then, I agree that even if the testing were negative at that point, it cannot, or it may not necessarily rule out completely the future of developing a malignancy in that aspect. So we always keep that possibility out, just like when we managing patients that we think that they may have intraocular lymphoma, but the diagnostic vitrectomy, we don't see anything, we cannot get testing. But again, if the cell continue to recur, in that case, we will relook at it again. And the situation of AIR here, if the finding may suggest that the underlying malignancy, then we probably will work up again. But certainly, Lucia, do you have any comment on this aspect?
No, I agree with what you've said. And, we've seen patients both that we follow that don't have cancer in the beginning and develop cancer, but I've also followed patients that have very clear autoimmune retinopathy for many years, 7, 8, 9 years, and they haven't developed cancer despite close surveillance. So, in those, we think potentially the immune system may be either keeping the cancer in check and never letting it blossom, or they have something else that's triggering the autoimmune retinopathy.
Maybe the appearance of a malignancy in the future is an independent clinical situation.
Yeah,
A
it is a very hard
coincidence.
link to make. I agree,
Anyway,
very hard.
autoimmune retinopathy is a distinct ocular disease.
In some patients, yes, I agree.